What we're now going to do is we're going to take a deep dive into issues around digital healthcare. Digital has been the buzzword in healthcare for quite some time. And what has now happened is you started to look at gaps and challenges coming within deploying digital healthcare solutions. While we do that, there are three areas which we won't want to focus over the next 1.5 hours, over the 90 minutes. We're going to talk about care pathways, we're going to get into health systems, and we're going to look at the role of an evidence lab. For the first discussion around care pathways, we have an awesome panel of discussants coming in. I'd like to invite Dr. Ashwin Naik. I've known you for quite some time. It's been more than a decade that we've known each other. I know him from the days when he founded Vatsalya Healthcare, which was delivering care into tier 2 cities. And today he's the founder for Manaah Wellness. He's worn multiple hats, but I think the best one I like is him authoring the entire set of books on healthcare entrepreneurship. Dr. Ashwin is going to moderate a session with three luminaries that we have. I want to now invite Dr. Sundaresh. Sir has been an inspiration for me, again, for more than a decade, instrumental in setting up a state-of-the-art first human cadaver lab in India in MS Ramaya, and currently the director of Sri Sathya Sai Hospital in Bangalore. I then want to call upon my very dear friend, Dr. Shibaji Chattopadhyay, Group CEO for American Oncology. He's been instrumental. He's been quite busy in COVID times, setting up 9 centers across tier 2 cities in India, and moved from emergency care to management and now into onco care, and wearing multiple hats as well. And then I want to call upon another dear friend, Devesh Varma, coming in from Social Alpha. He heads programs there. He's also the Chief Digital Officer. And Devesh comes in with a background of understanding the impact landscape, and they're kind of building certain community alliances built around redesigning care pathways. So over to you, Dr. Ashwin. Stage is yours.
Thank you. We should just call this Friends of Dr. Ambuj panel. From regulatory pathways to care pathways. Thank you, sir, for your enlightening discussion on regulatory pathways. I think the care pathways have always been something which is of interest to everybody, but it's always been a challenge to implement. So I am very delighted to have a eminent speaker panel here, Dr. Sundaresh, Mr. Devesh, and Dr. Shibaji with me. When I was thinking of my book, The Healthcare Game Changers, one of the theses I had was that the future of healthcare will be VIP square. VIP is an acronym for virtual, integrated, preventive, and personalized. I think that's the entire sort of emphasis of care pathways. And in the recent Niti Aayog report also, there were few highlights mentioned. If you have to look at the future of healthcare in India, what are the 3 or 4 things that need to happen? The first thing was around how do we complete the agenda of this unfinished public health in India, right? How do we make sure that public health reaches where it needs to reach? Second is, how do we empower citizens to take care of their own well-being, health and well-being? The third is, how do we make sure that all the systems that we have are integrated so that the care is affordable and also systematic? And finally, digital. How do we enable all of this in the context of a digital ecosystem? So in the context of that, to set the stage, I'd like to invite Dr. Sundaresh to not just talk about care pathways, but also demonstrate it with one example or few examples that really bring out the value of having a good care pathway. Dr. Sundaresh, maybe if you can get the slides up, please.
Good morning, everybody. Thank you, Ambuj, for putting together this discussion on a much-needed topic of changing care pathways for healthcare delivery in India. Well, I come from an institution which is 100% charitable, and I have something to say about that. Before I go into that, I think we need to, before we go into proposing any change, I think we need to identify what is the current problem. It is very rightly said that change is the only constant. We need to keep changing at all points of time. So most of the population in India, which is about 70% of the population in India, have no access to proper health care. They're all in the rural areas and they don't have access to proper health care. So before we go into doing anything more, we need to understand how we are going to deliver this health care to this population in India. So this is a paper which I have found, Redesigning Care Pathways in India, which describes very aptly what is the way of doing it without going into the aspects of everything that is shown in the slide. Just says that we need to assess what the problems are and how do you design and develop what is a plan of action and how to implement the models that you're thinking of. So considering that most of them are in the rural areas, they don't have access to healthcare, they are not affordable. Today it is known that how they fund their treatment costs is very sad. There are people who borrow money, there are people who sell their assets, and there are people who just don't bother to treat themselves because they can't afford it. And there are people who don't get treated because their caregivers are not able to spend time and money to help them get the proper kind of health care. The government contribution to this health care is just 30%. And 70% of the healthcare delivery is by private sector. And the 70% healthcare which is set up by private healthcare delivery systems is all only for those who can afford the treatment. There are not many institutions which offer free treatment or subsidized treatment to the 30% the 70% which cannot afford this treatment. So what we need to do about it is, having identified the problem, what we need to do about it is one needs to contemplate on and look at it. Number one, as the government has to increase its contribution to this healthcare. And then there has to be a robust public-private partnership which needs to be developed if we want this healthcare delivery to go across the country to all the people that really deserve it. The last thing is about philanthropy. Philanthropy doesn't come easily. It can be done, but it needs to be tapped into. People need to be convinced that there is a scope for philanthropy, and that is where we need to work on also. I would like to speak a few words on the healthcare systems with which I work. Well, I work in the Sathya Sai Institute of Higher Medical Sciences at Whitefield as director, and the founding body of this is Bhagavan Sathya Sai Baba. I would like to mention here that this is not a religious organization, it's a spiritual organization. And it's a service organization which has set up 5 hospitals completely free of cost, delivering advanced health care to all those who need it. There are 2 super specialty hospitals and 2 general hospitals and a mobile hospital. The mobile hospital is something which I'll talk about a little later. It's located in one in Puttaparthi and 2 at Puttaparthi, 2 at Bangalore, and the mobile hospital is also again at Puttaparthi in Andhra Pradesh. How has this worked? It's interesting to know. This has worked only on one thing, that there is a corpus which has been donated by the devotees of Baba. And that, the interest from that corpus is what is funding the entire hospital, not only the hospital, an entire education system, the university, Sathya Institute of Higher Learning, is also funded by this trust, which runs these institutions. And it's only by the interest which is earned by this corpus. And this is used for the revenue expenditure, and all capital expenditure comes from additional donations from these devotees. It's a very robust system which has worked from 1991, when the first hospital was inaugurated at Puttaparthi. The hospital at Puttaparthi has all these specialities, treating a lot of patients, and 271,000 patients have been operated free of cost. And all the surgeries that are done there is with the best of equipment and the best of manpower that is available. All the doctors, most of the doctors are fully employed. Only a small percentage of the doctors are volunteers who come from within India and from various parts of the world. A similar hospital in Whitefield, which I am heading at this point of time, it has all the specialties, mainly cardiac surgeries and neurosurgery. The cardiac surgery department performs about 6 to 8 cardiac surgeries, and the neurosurgery department performs about 8 to 10 neurosurgeries. And orthopedic surgery, I'm an orthopedic surgeon, I do a lot of joint replacement free of cost, which is all high cost treatments. So even this is totally free of cost to the patient. And then the general hospital at Puttaparthi. And then we have the mobile hospital. This is an interesting model which is worth looking at. There's a van, a bus, which is completely equipped with all diagnostic modalities, including an echocardiogram. It has the lab, it has a lab, it has an X-ray, it has an echocardiogram. And consulting doctors, about 400 of them are registered to work voluntarily with this hospital. All of them are mostly from Andhra Pradesh. They come for 12 days. If you look at the calendar of events, the van goes to a fixed point every month as the dates are suggested, and it goes on repeating itself. Therefore, the primary care delivered in these institutions is total. The only reason I'm mentioning all this is because I want to prove a point that there is a model which can work. And I don't think there's any dearth for money in our country. As we are delving into the area of digital healthcare, I think we should parallelly delve into this area of where we can get healthcare, reach out to the people who require it really. Most of the patients who are coming to the major hospitals, either at Whitefield or at Puttaparthi, you'll be surprised to know are from either West Bengal or Orissa, where the healthcare delivery is probably not adequate. So I stop here by just saying that there is a possibility that we can do. See, looking at this example, and we need to address the fact that there is something beyond digital healthcare which we need to do. Not that we shouldn't do that, but we should look at the fundamental requirement of the patients of this country. Thank you very much.
Thank you, Dr. Sundaresh. I think you brought out a very important point around creating access to 70% of the population. Maybe we can turn to Mr. Devesh just to talk about how technology can play a role in creating both this access and also the relevance of technology in developing care pathways which are relevant to a country like India.
Sure. Is this good? So thank you, Dr. Ashwin, and thank you, Dr. Sundaresh. I thought it was. Yeah. It always happens. So I'm the non-doctor here, but I will share my thoughts and especially try to articulate a response in terms of the question that you asked. What Dr. Sundaresh touched upon is an important aspect to look at. More than 65% or let's say 70% of the population lives in those areas which are hard to reach, or there are a lot of unmet needs in those areas. And if we are trying to solve a problem, and I'm going back to the whole why we should need or why should we need to focus on building care pathways which are contextualized or context appropriate, especially from an India point of view. Um, because if you look at the way care is provided or care is delivered, it can be looked at it from a first mile delivery or a last mile delivery, depends upon how you want to articulate it. But majority of the workforce that goes into the field, if we want to empower them with certain protocols or pathways which are distilled out of complex medical facts, which are novel, actionable and validated, I think it gives them the confidence to provide care to the beneficiary or the citizen. Typically what happens is that the ability to come to a decision in terms of identifying is not there to an extent which it should be. Because they are not asked to do that, because they are not equipped with the appropriate protocols or pathways which will help them identify simple cases of, let's say, high-risk pregnancy case, or what needs to be done if you find someone with a case of acute diarrhea, or someone with a chest pain who is walked into a health and wellness center or a sub-center. I think that's where building these protocols, which are heavily contextualized from the need that India has, will help us a lot. Now, technology becomes a logical adjunct because then it will help us in disseminating those. The idea is to build those around what India needs. So let's say if there is a case of silicosis in Rajasthan, or if I go to Bihar, Muzaffarpur, I see a case of encephalitis. Those are contextualized to specific regions in India, right? Now, if I get those protocols, build it to an extent, crowdsource it or open source it for other startups to come in and start building, let's say, decision support systems, very small, rudimentary decision support systems for frontline health workers. Imagine the impact that these systems will cause. While digital or technology are the easiest things to build, the toughest part is to crack how will a user use it, right? If I go and ask an ASHA worker or an ANM or an Anganwadi worker that, hey, here's a technology system, I want you to use it. We have to look at the human behavioral aspect also, right? So build those systems which are usable, which answers the question for frontline health workers that what is in it for me? It gives them the ability to decide. It gives them the ability to confidently decide. And either it results in the right treatment or a quick referral, which does not happen frequently. So technology that way will start helping people, and then you can start adding multiple different peripheral things where startups can come in and help in capturing those medical data points, right? It could be a point of care device, it could be an IoT device, it could be a handheld device, it could be a wearable. There are multiple different avenues to collect data points. But then how do we bring it all together is by thinking of one build pathway, empower the people to start understanding why this is important, to help them use it, and then leverage those technology systems to build solutions for them so that they can start using it. Is it a silver bullet? I don't know, but I think we should start looking at it. There will be challenges because technology adoption is a huge challenge. But that's how I think we should start looking at solving the problems with simplified care pathways, leveraging technology and distributing it.
Great. Thank you. I think that you made two very interesting points. One is, how do we think of redesigning care pathways using technology but keeping the front line in mind, right? How do we empower the ASHA workers or the community health worker? That's number one. The second important point you are making is that there is enough opportunity for startups to leverage that data to then build intelligent systems which could then create personalized sort of care pathways for a large number of people. That's great. Now moving to Dr. Shivaji, I think you are in a sector which is driven by care pathways, right? Oncology is sort of the early adopter of care pathways. And now you are contextualizing that in the rural, semi-urban area. Are you seeing major shifts or changes or challenges between what is happening in the sector in general and what you are implementing on the ground?
So, thank you, Dr. Ashwin. See, I'm a person who understands both the side of the table. Being an intensivist myself and being a management, seeing how care pathways have evolved in developed countries, whether in Harvard or the places. Yes, it's developing. The positive part of it is We have been talking about care pathways, clinical pathways for quite some time. I think if I segregate it into two divisions, in healthcare we usually work with a multi-speciality fragment and a single speciality fragment. Care pathways in single speciality has evolved quite a bit. There are pathways already available. Taking from what Mr. Devesh said, yes, there are certain developments in decision support mechanism which is evolving in a lot of EMR. The major challenge, what I feel, it's not about where the care pathway is being implemented, whether it's tier 1, tier 2, tier 3. I feel we clinicians are still a bit rigid about care pathways to a certain extent. We feel that why should a decision support mechanism take over my clinical decision methodology, correct? And we lose our touch. Since I work extensively in oncology, oncology is one branch where we have totally evolved into care path mechanism. Moving back to one step, like in ophthal, in cardiac, care pathways have always evolved. It's always there. Big institutes, irrespective of whether it's in tier 1, tier 2, tier 3. As Dr. Sundaresh said, we have been always talking about healthcare affordability. And I personally believe that unless and until we don't have a care path mechanism inbuilt into healthcare, nowhere the cost will come down. Whatever we try, we know we are talking about innovations. We are still 80-90% dependent on foreign imports, on medical devices. There is cost involved. The decision makers are not taking any decision of reducing import duties. In reverse, it's increasing. Prices are getting capped. So the only way we can make healthcare affordable is if we have robust care pathways. It helps in lot of things, like as sir was telling, we still have 80% out-of-pocket expenses. The lesser the patient stays, the lesser is the expenditure. The lesser the patient stays, the lesser is the cost of drugs and consumables. The last point I want to touch, have worked, being an intensivist myself, it's not very difficult to develop care pathways. We have tons and tons of data available with us. We clinicians, we know what is happening with a patient, except a few modalities where we have a polytrauma patient or a really sick patient coming in, which goes into a critical care setup. If that data is streamlined, if that data is properly analyzed by clinicians, correct? I think care pathways can be possible in each and every disease. It's possible. In single specialties has happened, only in multi-speciality, certain plant cases already it's there, correct? And I feel coming directly from the industry, a person of operations management in healthcare, I would always support a care pathway. We follow it in oncology. I had implemented it across my company, correct? We don't deviate a single bit. In many of multi-specialties where we have worked, we created something known as a basket concept. If we have a robust care pathways, we can predict how much consumable is required for each and every patient. How many syringe, needles, everything can be predicted out, correct? So we have done that, yes. We need some sort of support from EMR developers. Some of the EMRs are quite exhaustive. As sir rightly pointed out, the end user, I prefer, it's easy to convince an ASHA worker to use a care path, but it's very difficult to convince clinicians like us to follow a care path, correct? So if we can have simple decision support tools, which many of the EMRs are inbuilt, I think we are reaching there. So that's my opinion.
Great, thank you. Again, you touched upon one very sensitive topic, which is clinicians' adoption of care pathways, but also technology in general. I think that's an underlying theme across the sector. We'll come to that. And the second one, what you are saying is, adoption of standardized pathways or care pathways is not only good for clinical outcomes, but also operationally for clinicians and hospitals. Coming back to Dr. Sundaresh, I think building on what Dr. Shibaji said about clinicians, I also feel that we are at a space or juncture in history in India where the health system is being transformed, whether it is Ayushman Bharat or digitalization or whatever is happening in this sector, right? Things are changing rapidly. The challenge, however, is the medical education system is still stuck in the past. Do you think that there is an opportunity now to redefine education, training of medical students to be prepared for this in the future?
Yeah, I agree with you that delivering healthcare has a direct relationship with how the medical education system works within our country, because that's the production line for the healthcare workers, essentially the doctors and nurses and other paramedical staff. Today, the cost of education in our country is phenomenally high, and that could be one of the reasons why we are not able to get people to go out to the periphery to practice the art of medicine. Number two is there's a fundamental deficiency of manpower in the areas where they are really required. That is the reason why all the efforts of the government have failed in delivering the healthcare to the rural people. The government's efforts are tremendous. There is no question about it. They have set up primary health centers everywhere. In fact, a lot of primary health centers have been equipped also with a lot of high-end equipment or whatever required for that particular region. But unfortunately, there is not a doctor there or a nurse there who is willing to stay and take care of the patients in around it. That is the basic problem. So therefore, the medical education system has to be used to extend these services into the rural areas. Towards that, the government's decision about starting a medical college in every district in the state is a wonderful thought, because it not only produces more doctors, I hope it doesn't create unemployment, but at least then people will go to the periphery because they don't have jobs in the cities. But at least the hospitals that are developed in these areas in district headquarters will serve a huge population in and around that area, number one. And the other problem of why this cost of medical education is high is because of the regulatory authorities. The regulatory authorities are still sitting on rules which have been made by the British for us. Unfortunately, it is not practical anymore. Sharing of resource is a huge problem for anybody who wants to start a medical college, who has started a medical college. They just don't allow sharing of a resource. It doesn't happen. They don't believe in somebody coming for 2 hours and 3 hours and taking a lecture and going back and doing whatever else he wants to do at that point. They need to have persons employed full-time. So all these things cost money.
Right.
There was a rule when they said we need 30 acres of land to start a medical college. But now it has come down. So these are the issues which increase costs of medical education. So the people who qualify out of such systems naturally need to make that money.
Right.
They can't do that in the rural areas, and government can't afford to pay so much money.
Right. Thank you. One of my hypotheses is that if you have to fix healthcare, we have to stop relying on doctors, right? So, in that context, Devesh, you are focusing on building this capacity at the community level, right? So maybe if you can share, if the doctors are not willing to go to these places, how do we build capacity in the smaller towns or villages where there is this need?
I think, especially if you look at India as a country, I think that's an important aspect to look at. One of the things that we talk about in Community Science Alliance is the aspect of task shifting. How can we empower people at the last mile / first mile to take those decisions which can then help, let's say, doctors who are sitting in higher health facilities, right? Will we be able to staff every sub-center with a medical officer or a community health officer who is equipped in the clinical aspect of treatment. Well, time will tell. We don't know. We're still trying to figure out how do we build those health and wellness centers, right? But I think it's important to look at how do we do the task shifting ability, train those people, give them enough in terms of training enabled by technology, and of course, yes, pathways also, which will at least give us the ability to stop the migration which happens, which also goes back to what Dr. Sundaresh cited, which is the out-of-pocket expense. One, at a village level, people don't tend to move out because health is not a priority, diseases. And whenever they move out, they go to places where they spend a lot of money because the peripheral centers are not working. So equipping those through pathways, through technology, will help us solve that problem. We may not be able to have one doctor, the ratio will come down, but we still, because we are 1.4 billion, we are not a small country. So we'll always lag in terms of qualified doctors vis-a-vis the ratio of patients. But I think that's one way to look at it. The other way to look at it is, I think, if you look at when we were hit by COVID, right? And I'm going back to pathways and the medical education bit. I think it's important to also look at what was happening. And I, not being a doctor, I just am citing as an example that the type of treatment lines were different. And I think the doctors will agree that because there were no set protocols, right? People were either thronging to higher health facilities because the peripheral centers were not treating them because they did not know, right? And the patients were being given a lot of things like ivermectin, I forget the name of the drug, but you know what steroids, yes. Because nobody knew what was hydroxychloroquine, yes. Because the pathways are not set. Now, if we go back to the medical college, not going into how to set that up, but looking primarily from when a medical student gets out of the college, if we build these pathways to an extent that they become ingrained in the medical education, so that when they get out and go do rural medical postings, they will be able to start using this, and this will become part of their psyche. They will start using these pathways, which will be standardized across India, so that, especially from a primary care point of view, we are going to solve one big problem, which is the disparity of treatment. Because if the pathways are structured and evangelized and given to every medical institute, the students will start using that structured approach. So that will solve a lot of problem also, right? But now going back to the primary care bit, it all goes back to task shifting. How do we look at enabling those frontline health workers, medical officers at a PHC or a CHC, giving them enough in terms of understanding of clinical pathways, simplifying it, and giving them the ability to decide, giving them the confidence that this is okay for you to read, learn and decide and do the line of treatment. And then save a lot of lives at that level, not having them migrate or go to a higher health facility, lose a lot of time. Not only just for pandemics that hit, but also smaller things, like I said, high-risk pregnancy cases, chest pain cases, or diarrheal deaths that happen, anemia cases that happen, which result into high-risk pregnancies, right? So I think that's one way to look at it.
Great, great, thank you. I know we are short of time, so I'll wrap up with one more question. But if you have audience has some questions, please do ask before we wrap up this session. If you have some mics here, we can circulate. While that is happening, Dr. Shibaji, one of the challenges that you mentioned is adoption by clinicians, but also to think about, as we go about redesigning this, what role does contextualization play, whether it in the social context or geographical context or whatever? Is there a significant shift? Are we looking at it from our cultural, our social perspective when we design these care pathways, or we are still in the sort of
See, it's a debatable point which you raised, Dr. Ashwin. Now, I'll just say a few words what Mr. Devesh said. See, we were training some clinicians in Delhi, correct? And I feel that whether it's social, I think care pathways, if we now have a very robust program of rural posting, correct? I feel when these people are getting inducted, it's a one-day session, because PHCs usually handle close to around 10-15 major diseases or minor diseases, which is more or less relevant across the country, it's very easy to induct clinicians with a care pathway. Now, in super specialties, yes, we could do that, because one of the major things which I have seen is in healthcare, we induct clinicians. If we have a proper induction of clinicians, and in that if we have care pathway inbuilt, it's very easy, because care pathways releases a lot of time of the clinicians himself also, which people don't understand, because it has a flow, it has the entire line which a patient should follow. It has bylines if a patient is deviating, if these are the. So it's very easy. It's only about the intentions. And what I personally feel, since Ayushman Bharat, Dr. Ashwin, you brought out, slowly care pathways will by force come into place, because with regulations coming in, correct, and regulations, I don't mean the GOI regulations. We still are miles ahead. We don't have the health repository still not ready. But with this type of packages coming in, we clinicians are forced to follow care pathways, because we don't have any other options, because we have to keep cost controlled. One of the major things which both Dr. Sundaresh and Mr. Devesh said about primary healthcare, I think to a certain extent, NRHM started care pathways in certain of the diseases. Yes, in primary healthcare, care pathways still is present. Only thing is the documentation part of it, correct? If a proper documentation, NRHM do collect data. They have certain protocols so protocol is somewhat a step down or a glorified form of care path, correct? Only we call them care path, and protocols is just a synonym to it, correct? So I still feel that when we are inducting, or when the people are joining, whether it's public or private, if as CEOs or people from private sector, if we spend one day time with a clinician, make them understand, because technicality they all agree, if we can spend time, showcase that how a care path will benefit you rather than the patient, I think it is possible to implement. The other side of it is, yes, we need to do a lot of work on developing care pathways, because care pathways is very dynamic. It is not static. In some of the disease, it might be static, but as clinicians, we have our subgroups in all our IMAs. We have physician associations, surgeons associations, correct? If we make them active, I think we can develop a more robust, more precise, more predictable care pathways. Because what I feel in care path, we talk about cost, we talk about resource freeing up, but many of the care pathways are still unpredictable. So there are a lot of uncertainty still built in, because we don't keep on evolving the care path. So this is my submission.
Thank you very much. If you have any questions, can we get one microphone here, please?
Fabulous discussion. Thank you so much for all of your comments. My name is Anunaya. I represent Jhpiego. One quick point that we've heard as a retort, maybe not exactly against care pathways, but as a counterpoint to it, is, are we being too linear in our approach? You can get to care pathways, and then we suddenly start talking about precision medicine, both from a patient perspective and also precision medicine from a community perspective, precision public health from that perspective. And so what is your take on that? Or should we really be going down the care pathway route, or and given now the Ayushman Bharat digital mission and everything that we're talking about, putting a patient and an individual at the center of care itself, is it fundamentally then beneficial for us to start going beyond it and going down towards cohort-based care and precision medicine in itself?
So, see, what you used as a precision care, correct? This, I feel, is also a part of the care path, correct? So, we have protocols. When we document it, we make it into a paper, more structured flow diagram. We create a care path. ultimately what is CarePath doing is what you absolutely said. The outcome of it would be very thorough precision care. That's why I said in my talk that we are not evolving. We are creating one care path and remaining static. Care path cannot be static. A lot of factors has to come in. We have to discuss, and we keep on evolving, and that's how we reach to precision care. And precision care is slowly moving. It's there in every specialty now. People are moving into precision care, and if we don't have care paths, correct, we can't reach precision care. How much technology you bring in, there has to be a usage pattern. I always call care path inbuilt with usage pattern, whether it's a drug, whether it's new innovation, whether it's technology. The more we use it in a structured way, the more precision care will come in. So these are all three interlinked, I suppose. We start with protocols, move into care path, we keep on evolving the care path as and on new dimensions are coming into our observation, and then we ultimately reach into precision care. Now precision care is also not static, it's dynamic, because we have seen it that there is no base known as precision care. It's moving slowly into that last 6 sigma mile where very less error is there. So these three are all linear.
Great. Thank you very much. With that, I want to thank the panelists, Dr. Sundaresh. Unfortunately, I think we are running out of time, so maybe we can have a one-on-one conversation. Just to summarize, I think for me, the key takeaways were, one is how do we redefine care pathways by focusing on medical education and training, number one. Number two is how do we leverage technology to focus on empowering the last mile or the frontline workers where care pathways might be more relevant or more appropriate. And finally, adopting good care pathways is really the way to push affordability and access. And finally, the point that you made out, which is what is care pathway? Is it leading us to a linear sort of approach? My sense is that care pathways have been led by clinical protocols. In the future, there will be a component of the patient themselves playing a part, right? And the families playing a part. So I think it will be a combination of clinical pathways, then patient-led pathways, and maybe some community element as well. Because I think, after all, health is a social subject, right? So with that, thank you very much to the panelists, and thank you all for patient hearing.
Thank you so much. And my takeaway on this entire session was, if you're looking at care pathways, they need to be inclusive, which is that they need to have multiple stakeholders coming in. Second thing is it has to be dynamic. So and that's an interesting point. And third piece is it has to be collaborative. When I see some collaborations coming out after the session, we'll have a talk on the sidelines. With this, we now. Sorry? Oh, and care pathways have to be photogenic. So yeah, so we get that part.
That's his pathway to follow.
With this, we now move on to the next session. I can see that we're quite late, so we'll probably have to rush into the next session now. So here's the next one coming in. I now want to invite the moderator for the next session. This is going to be on health systems, strengthening health systems, actually. And the moderator, Dr. Anunaya Jain, country digital lead for Jhpiego. You already made your mark with your question, so let's see how you how you take the thing forward. And then I have the privilege to invite Dr. Krishna Reddy, currently the country director for Access Health, associated with a wealth of experiences across the healthcare system, right from being a clinician to then now getting into the entire advent of building health systems. And then Welcome once again, Sharad Sharma sir. Co-founder, founder for iSpirit Foundation, but for me, a mentor, specifically on when I look at digitization of healthcare. And so with this, I pass on the con to you, Dr. Anunaya. Over to you.
Maybe we can follow COVID protocol today. Good afternoon, everyone. Thank you very much for joining us for what we're calling the fireside chat. And today happened to be a day when Delhi was below 15 degrees centigrade. And so it's perhaps the right time to have a fireside chat. But again, a warm welcome to my co-panelists today, and again, a wealth of experience from them. So unlike Ambuj, what you said, it's less of a time for me to say anything, more of time for them. But on this session, we're probably going to grow up a level, right? We're going to take a systems and an ecosystems view onto what can happen as the future of healthcare is concerned. And so this is going to focus on building resilience in health systems and what does it take in order to really drive our systems towards that. Just as a very simple contextual point setting piece, I think all of these conversations started to happen because of COVID, but health systems resilience really starts before a crisis even happens, right? So it's about building that spring which can absorb the shocks, which can recover from the shocks quickly, and which can perhaps evolve stronger. But everything starts with a little bit of introspection always, right? And so let me call upon you, Dr. Reddy. I think we've all seen how COVID's really affected us. We've seen how our healthcare system in India, healthcare systems across the world, just because of the way that the data was made available to us as to how health systems across the globe have responded to COVID. And so could you give us your views on how you think we've performed as far as COVID response is concerned? What was our resilience that came out? Or were there lessons that we can learn from other health systems that perhaps will become a guiding point for us as we go forwards towards building a stronger health system itself?
Thanks, and I think just as a clinician, we do the mortality meeting and morbidity meeting. So the COVID is like a system level assessment from a clinician's perspective. So I think that the first assessment, if we look at from an Indian perspective or the global perspective, the three core objectives of the health systems and what are the outcomes related to that. The first outcome I think anybody sees, whether the system performed or failed, is what is the mortality? What were the excess deaths that the population had? Could these deaths be prevented? Whether any country could prevent these deaths, we have examples. So fundamentally, any health system outcome measurement is, did it prevent deaths? So that is fundamental question. I think there was a lot of debate on actually how many excess deaths that happened in India. It should not have been there. I mean, why the system is not able to measure how many deaths have happened in the country? It's not difficult. I think in a village, the serpent should know how many excess deaths have happened. So this is, I think, the fundamental to beginning of learning what happened during the COVID. So that is one aspect. The same way, we should know how many disabilities are there. That means how many patients with long COVID are there, how many patients are left with damaged kidneys, damaged lungs, and the damaged hearts are there, or damaged brain is there. Because this is the lifelong disability that has been left by the COVID. So third aspect is in terms of the responsiveness of the system. From a patient perspective, do they trust the health system after the COVID? System they trust. Is it the private system they trust or the public system they trust? So that is the one aspect, because if the trust is not there in terms of their health needs were not met during the COVID. So that unless we understand those aspects of it, in terms of the meeting of the health needs, when I look at in terms of the access or affordability or the quality of healthcare. So the last aspect is in terms of what are the financial hardships the population faced. So how many people were pushed into poverty because of catastrophic health expense? So my take is that we begin with first finding out these outcomes as a part of our learning system. Like any proper assessment, then we go to the 4 fundamental functions of the health system in terms of the provisioning of care, in terms of the financing of care, in terms of supplying resources for care, and in terms of the governing. Because unless we look at from a systems approach, we will not rectify this. We'll be only transactional. I mean, this worked well, so we do this worked well. Telemedicine worked well, let us do that. So I think that approach may not be correct from a complex systems perspective. The third is in terms of the structures delivering these functions and the processes. How weak are these structures? How weak are the governing structures? I mean, we always look at from the global health architecture, but we don't look at the architecture at a village level, at a municipal ward level. In fact, our looking should be starting from there. Whether it is the governance of the local system, the functions are same at a village level. How do they function the health of the village? How do they actually provide healthcare in a village? So why don't we empower that level? Why do you look at from global level that we criticize the WHO or the economist or the IHME which produce the excess health deaths data based on complex statistical calculations? Whereas you can have a real deaths to know what were the excess deaths and what were the cause of those excess deaths. Having said that, if we have to assess our performance around these parameters, yes, we did encounter deaths which could have been prevented. We do have disabilities which could have been prevented. We did push people into the poverty which could be prevented. But the positive side is that the tremendous resilient response of the entire system, I'm not talking about the government or anything, but the civil society, the private sector, the public sector, the ability to ramp up the personal protective equipment in a short period of time with no stocks to surplus stocks for exports. So we have to learn from that, how we did that and how do we build that as a new normal. The same thing with vaccine. The ability to develop vaccine, the ability to manufacture vaccine and ability to vaccinate 2 billion doses. So that is a great achievement. I would say that's the most positive achievement which we should not. And similarly, the the policies which were announced as a part of the COVID response, in addition to the existing policies of health and wellness clinics and the PMJ to move towards the universal health care, you have announced the digital mission. Okay, that is a transformative, just like the biological systems, unless your nervous system has evolved, you don't become complete. Right? Similarly, unless the information system integrates these complex social systems of the human social systems, we won't evolve. So it is a must. It's a natural step of evolution of social systems that we need to be integrated by an information network that only ensures a coordination. With the health system in isolation, it cannot work. We are fragmented. So much of private care. So that is, I would say, is the most transformative step if implemented properly to leapfrog our health system, whatever gaps that we have in terms of the access, in terms of affordability, in terms of implementing the care pathways in the most efficient fashion. So I think that was one, I would say, the important policy that came out. And second policy that came out is the Ayushman Bharat infrastructure mission. That means you are addressing the structural aspect of it. The information system integrates the entire fragmented complex system. And the infrastructure mission is attempting at strengthening the infrastructure right up to the village level, including the health and wellness clinics. So I think these are, as a part of this, in fact, we have initiated the Global Learning Collaborative, that how do we systematically develop that learning health systems culture at a district level, at a village level, at a state level, at a national level, regional level, and global level, so that you don't depend upon some research studies coming from the global academic institutions. The state should have that capacity to assess their own health system, to manage these complex health systems. Yeah, these are some of my takes in terms of what would happen, but what should happen in the future for resilience buildup. Thank you.
Thank you, Dr. Reddy. I think some very big sound bites that you just provided around how it's important to look at this from an actual systems perspective by first focusing on measurement, by making sure that you're addressing all different aspects of healthcare as to how do you really build trust, how do you really evolve not just healthcare delivery, but also perhaps financial security as a part of universal health coverage itself. But Sharad, let me quickly turn to you as well. Obviously, health systems resilience and building strong health systems isn't just about response to pandemics like COVID, right? Global search shows that there are so many other shocks that prevail across. If we truly have to deliver equal care to everybody equitably at all points of time, are there any overall system gaps that you're seeing that as we lay out intervention targets for ourselves over the next 3 years, 5 years, 10 years, that we should perhaps be focused on in order to build these stronger healthcare systems? And any recommendations on upfront as to how startups and how the ecosystem should then start to look at these?
So if we look at universal health coverage, we know we're not doing very well, right? And I think you alluded to that. And I think except in some areas related to vaccination, there were a number of problems that were resurfaced. They were known and, it wasn't as if they were not known earlier. Now we know that there are countries who can solve this if they spend $2,000, $3,000 per capita. You can look at European countries. We know also that below that, there have very, very few success stories. I mean, the only one that is worth mentioning is Thailand at $700. Can we even spend $700 per capita? No, we cannot. So first, let's frame the problem. Our problem is that at $230 per capita, can we provide universal health coverage? No country has done it. Many don't attempt it because in their view, this is not even possible. So this is the first way to look at this. Now, is there a possibility that we may be able to do it? I think yes. For that, we have to go back to our own recent history. First, in the 90s, we were able to reimagine how stock trading used to happen. NSE and depositories, we take it for granted. Screen-based trading came in India first before it came in most other markets. Even today, NSE is one of, by transaction volume, the largest exchanges that are there. We have had electronic depository receipts for a long time. Then we went out and tried to fix the voting system. And by and large, we did it, except for the voters list. The fact is that our EVMs are needed elsewhere in the world. I mean, and Americans should certainly take them on. Then I think in the last 10 years, this has been the biggest revolution that is happening. So if you go to 2008, only 1 in 25 had a formal ID. You go to 2011, only 17% of the people had a bank account. In 7 years, we gave more people bank accounts than on an average. This is a BIS study. Most countries took 46 years to reach the same penetration. Today, we have managed to democratize payments in a way that nobody has thought of. We managed to do that with data. So now the benefits of that are accruing in the financial system because you can now do credit, cash flow lending in a way that was inconceivable before. So when actually COVID happened, there is this seminal meeting that took place, and I know Mr. R.S. Sharma could not be here, is that we normally vaccinate 25 million babies through our existing 40,000 vaccination centers. And it was clear that we would have to vaccinate 1 million people. And the discussion was, do we need 20x the vaccination centers or 10x the vaccination centers? That was the conversation that was happening. An alternate point of view, which was finally adopted, was no, maybe we don't need more vaccination centers. We just need to streamline the flow of people, in money and information through the system. So the fact that we had 2 billion vaccinations in 1 year is because we could use Aadhaar, we could use DigiLocker to give everybody a certificate, and almost all vaccination centers, especially the private ones, did receive payments on time. At least nobody received, had big issues enough that they would reach the press, right? I'm not saying that it was imperfect. So the question, I think, it ended up being something that we don't appreciate, which is what ABDM is. That in any system, if you reimagine the flow of people, money and information, you can unlock productivity. In this case, since we were able to do 25 million people vaccination every week, we unlocked at least 50x productivity in the same system without training of personnel in a big way, without anything at all. So this is the opportunity that is sitting in the health system today on a larger basis. However, is this going to get us where we want? From where we are with UHC, answer is no. Many other changes that would be needed. Some of them have been alluded. For example, with respect to pathways and protocols and related to that, and we can cover that in more detail later. So the first point is that there is something we must appreciate that is happening, which is there is a streamlining that is taking place. Instead of Aadhaar, we're going to be using Aadhaar ID. Instead of DigiLocker, we're going to be using personal health records. And instead of UPI or IMPS, we're going to be using e-Rupee, which is a voucher system. And the voucher system has the potential to completely transform the health system. Why? Because the leakages can be stopped, right? So when you have a mother who delivers an underweight baby, she's supposed to get protein biscuits. Only half the state she gets protein biscuits. The other staff, only the register says she gets protein biscuits. But if you give her a voucher that she can redeem in a pharmacy for protein biscuits, then you disintermediate the corruption in a very big way. So that's coming. For hospitals, the health claims exchange has already been announced, so that is coming. So revamping of plumbing is definitely going to happen. Now in this, there is embedded in this a very big idea. And this is an idea that is coming from other areas, which is often not appreciated. That look, it is going to be a combination of public technology. Public technology does not mean government technology. PHR is not, the protocol is not government protocol, it's actually a public protocol without it being a government protocol. It involves public technology and public policy. And the question is whether we'll be able to synthesize these two like we have been able to do in the financial inclusion sector in a very meaningful fashion. Why we've been able to do it in the financial inclusion sector is because there has been a set of regulators, RBI and SEBI particularly, who have been very progressive, who've been in the regulation business for a long while. So you may have the ministry which may be taking a myopic view, but you have a regulator which takes a slightly more progressive view. That formulation does not yet exist in health. Very often our ministry is both the provider and the regulator. And we will need that reform as we go forward. So I think we will need to reimagine health is as a combination of public policy and public technology. I'll come back to that a little later, if there is time, but I'll stop here and hand it back.
Yep, sure. So let me pick up on some of the things that you just said. And one of the pieces that we will need to fix is the misaligned incentives that are there within the system as well. I know we've had an independent conversation about that, but can you elucidate a little bit more to that? Because I think that perhaps is even more germane to the entire story here than just the plumbing.
It is controversial. I mean, you can see, the best way to see this is Canada versus the US. We know US spends a lot more money and has poorer health outcomes than Canada, right? Now look at India. In India, if you were to look at $230 as the spend, we have Kerala which actually spends it within the government system. And on top of it, you can add out of pocket. So we have a state, Kerala, which has got actually enough money to get to UHC. But this is also the state that has one place where the cesarean births are 94%. In one big district of Kerala, they are 56%, right? So what is happening is more money is going in the wrong direction. People are using that money to do unnecessary cesareans. And I'm only citing that as one example. There's data to indicate there are many more things. So the result is that we have the same phenomena that is emerging, is that if you have more money, you don't see a correlation with better outcomes that you talked about. What you see is more misaligned incentives and more wastage of that money taking place, with almost no material actual improvement in the health of the population that you're looking at. So this is, in India could well build a system which, as we put in more money, this becomes even progressively worse. And we have a wonderful country to look at as an example of this, and it's called the US, right? I mean, it's a paragon of, misaligned incentives that work for anything and everything, to the point that they can't even preserve for the last few years their lifespan of their population, right? And look at what's happened with the opioid crisis. I mean, a completely perverse incentives at work. So if at all, I am glad you brought this up. We have to therefore look at it from what we call it as the open networks perspective. Because otherwise monopolization, rogue intermediaries are all going to come in. Now this requires a little bit of a techno-legal regulation, because you can't have just regulators saying thou shall not do it and it will stop happening. It doesn't work like that. And so therefore it requires market architecture and deep type of market policy thinking that needs to happen in India. Otherwise we will not make progress.
Great, thanks Sharad, thanks for that. Dr. Reddy, one more oft forgotten aspect to building resilience is the human resource aspect of healthcare itself. And I know you as a person have been at the forefront of this, you're very passionate about it. But how do you build resilience within the human resources within healthcare itself? How do we really look at that aspect of healthcare provision?
Yeah, one is we need to redefine the WHO benchmarks in terms of the doctors per population or the nurses per population. In terms of adequacy of the human resource, it is the demand supply. Suppose I need a consultation of a cardiologist for an elective thing, or I need a joint replacement, I need a bypass surgery. What is the waiting list in India? It is less than 24 hours. What is the waiting list in NHS? What is the waiting list in US, where you have 4 doctors per 1,000 population? We have less than 1 doctor per 1,000 population. So we need to redefine what is the adequate number of human resources required for people's health needs in a way if it is given. For example, the previous session, there was a clear discussion in terms of if you're breaking the same functions of a doctor or a functions of a nurse or a functions of a frontline health worker into a doable works, and the competencies required to that. And some of those competencies, some of those things can be done by many other people. For example, for a doctor in the US, he sees 10 patients per day. I see 100 patients per day. But in terms of the medical records, I generate the same because I don't type it. But I ensure that the essential data I capture, or some of the data is automatically captured from the laboratory equipment. So we need to rework, re-engineer the entire process. I think the previous discussion in terms of the care pathway, that is the only thing that drives efficiency. The second thing which he alluded to in terms of we should not follow the same pathway of incentivizing, what we call the strategic purchasing. I mean, once we are evolving towards that pooling of the purchasing. I mean, today we are paying out of the pockets, but slowly we are moving towards pooling of the purchasing, because see, the government has now 500 million people under PMJ, 200 million under ESI, and 30 million under CGHS. So it's moving towards that. And I'm sure before the next elections, the missing middle also will be coming into this pool. Especially as the economy becomes the digital, the informal labor is shifting to formal labor. Once it shifts to formal labor, automatically they come under the social insurance. So the entire architecture, I think the technology is pushing our society into becoming more formalized. So that means when you become a single pool, then you can actually drive strategic purchasing to derive value. I mean, at what cost you get the best outcome. For example, if 100 deliveries are done at this cost, why should somebody do cesarean unnecessarily? So I think we need to move towards that value creation, and it is achievable. Mind you, I mean, for the current spending of 3% or 3.5% of GDP, the volumes that we have, the output we have is much greater. If you really calculate the value of the services that we are delivering, much greater. And this is at a level where 20% of the sanctioned budget is not spent every year. Then if you calculate the value of low value services or no value services, that means the drugs not needed, consultations not needed, procedures not needed. If you eliminate that, you save another 20%. We have enough money. Actually, the current money, you can give much superior outcomes. So we need to approach that systems approach to derive. I mean, I think we are in the right place. We may be like India for the world. We can become the example for the world in how you can drive efficiency, access. I mean, you have unimaginable access. Rural villages also, if they want to have access, today we have an access. I mean, if ASHA worker is just trained to connect with them with a consultant, WhatsApp, they can consult. I mean, most of my patients, in fact, they are now consulting from the village. They don't come to me. I say, you don't come to me for 1 year. So it is possible. I think it is possible to make it as efficient and give the best value for the money. I give an example. Bypass surgery, when I started my cardiology profession 35 years back, we used to charge 1 lakh. Today, Arogyasri pays 1 lakh after 35 years. But still, we are able to do that and still survive financially. So there is a way to innovate.
No, absolutely. And Dr. Reddy, you brought out a very strong point of being vocal for local, but with a global voice in many ways. But let's go a little bit more deeper down into it. And Sharad, if I can peel that layer of the 20% savings that Dr. Reddy was talking about and further 20% of savings that could potentially arise from unnecessary procedure itself. Is it that our focus needs to start changing as well? Should we be looking at chronic care and chronic diseases that are potentially the next shock waiting to come to us? Should we be aligning ourselves perhaps with more point of care testing and more biomarker testing than with just protocols themselves? And so your thoughts on where that next level of investment should potentially go into?
So as some people have said that the biggest disease that we have is people don't follow the regimen, right? And IKP itself, I think, did a seminal challenge grant back on TB regimen adherence. And that is universally the case, right? I mean, people with diabetes have that problem, and people with hypertension, and and the problem is that we have these rich country problems, and our budget in the rich countries, the budgets is being taken care of by these, is being eaten up by these chronic diseases, right? So this NCD element we have to reimagine in a very big way. And if we don't reimagine that, then whatever money that we have set aside will be eaten up with that as we go forward. Now, is it possible to reimagine that? And many of us believe that the answer to that is yes. And why is that possible? Because I think we have to find a good way to nudging people. The TB Challenge grant indicated that simple solutions can lead to big outcomes. But there is also something else that has happened in the last few years. And the good example of that is TikTok. Now, TikTok we don't appreciate in India because thankfully we don't have it here. But TikTok has more minutes spent on it than Netflix has. And so now TikTok is the same system that operates in China and the same system that operates in the US. The difference is that the hand on the scale is looking for different outcomes. The hand on the scale in the US is now been proven, designed that the people in the US start hating their own country. The hand on the scale is designed in China so that they start loving their own country. That same damn system, same company, two different outcomes. It is one of the most significant A/B tests that has happened in the world. But what does that A/B test prove? It shows that it is possible to change societal thinking using the media, social media that we have. The question that is in front of us is, can we find a way to do this so that we get better adherence? Can we do it in such a way so that we have more frequent OPD visits? Because that's a key element of being able to make sure chronic care is happening well. The doctors are beneficiaries, the patients are beneficiaries. Maybe that needs to happen on telemedicine, right? So that the time spent is very minimal. Maybe it requires group consultation to be possible in telemedicine so that it's actually more effective than it is possible. So I like to say there is an experiment like that that is happening as part of something called the Open Health Services Network. So clearly chronic care we have to reimagine it. We cannot import a Western system because they are broken as it is. They are the Visa MasterCards. We have to think in terms of Paytm wallets and UPI. So we need a completely new ground-up thinking, first principles thinking, and I think that will come about here in India. That's point number one. The point number two, I think, is that we know from the Japanese experience that if you want to deal with, let's say, things like oncology, early detection makes a world of a difference. And I think because of the Moore's law that is working in point-of-care terminals, because of the data infrastructure that we are creating, which Professor Desai alluded to in his talk yesterday, we are in a position to actually take an aim at early detection in a way that was inconceivable just 5 years ago. Third is that we have to go for preventive care. And in fact, culturally, we are the only country in the world where preventive care is part of the culture. I mean, we are the country that's given yoga to the world. We have this mindset in our population that they embrace the idea of preventive care. So I think if we have to aim for $230 million beyond, everything else, there are three big ideas. Can we reimagine chronic care? Can we bring early detection to the large population of India? And can preventive care be amplified in a way that we cannot conceive of today? So that would be my answer.
Perfect. Thanks, Sharad, for that. Dr. Reddy is on the same topic. I think Sharad's given the three primary interventions that he'd like to focus on, but perhaps a couple of interventions from your end where we should start to focus our attention on as well.
Yeah, I mean, when we talk of health systems, we keep on talking of the health budget, and this is the budget percentage of the population. But people don't look at the budgets which influence health. The budget on Swachh Bharat, the budget on Ujjwala scheme for indoor pollution, the budget on Jal Shakti for clean drinking water, the budget on clean energy, the budget on communication. So I think the investment should start with the social determinants. So that should be part of, should be considered as health budget actually, not just pure on curative care budget. Normally we equate curative care as the entire healthcare budget. No. I think that is the first thing is we have, because the longevity, if you look at longevity of the population, 72% of the longevity is on account of social determinants, not because of healthcare delivery. So budget has to be invested there, and the value for money starts from there actually. Then as a person, I mean, because we cannot also deny the benefits of the advancement in the technologies at a personal health level. That is where the precision medicine comes. But to make me access that advanced technology, not deny me the advanced technology, I save money by the primordial prevention at the social determinants level, then the primary prevention, then early detection. So the prevention, I think many people think prevention means only primary prevention. No. The primordial, primary, secondary, tertiary, and quaternary prevention. For example, if somebody has an acute MI, if I don't prevent the heart failure, okay, because heart failure, once it develops, the average lifespan is 3.5 years. But if I don't treat again heart failure as per the evidence-based guidelines and emerging technology, what was 3.5 years? Now I make them live around 15 years with good quality of life. So we should not deny advancement in technology, but at the same time, how do we extract money by the entire value chain and continuity of care, right up to the end of life care. I would say you plan from womb to tomb. The malnutrition of the fetus actually predisposes them to NCD in the future. Okay. So, as Sharad said, I fully agree that there is a need to reimagine, and we have to decolonize ourselves from the Western thinking. I think we can think originally. So we need to change the benchmarks. Change the benchmark of 1 doctor per 1,000. It may not be required. I mean, doctors are for the cognitive purpose, right? Rest of the thing, data collection somebody can do, imaging lab equipment can do. Even the cognitive function of a doctor, like a dermatologist or a pathologist or a radiologist, now AI is able to do. That means one radiologist reading 10 X-rays now can read 1,000 X-rays because your processing is much faster. So your productivity is going to increase. So you have to redefine the human resource benchmarks in terms of the doctors needed for how many people.
Perfect. I think this is a great opportunity for us to bring this conversation to a close, and I could continue having this conversation for several hours with the two of you. But perhaps the most significant takeaway for me and for all of us is the need to have redefinition of sorts. Redefine not just what we measure, what we aim for, but also perhaps redefine what health is itself. Health cannot be a singular concept just constrained around service delivery and care delivery and diseases itself, but perhaps we really start to embody what One Health is, which is bringing together the concepts of climate change into healthcare, the interaction of agriculture with healthcare, the interaction with all of the other social determinants that perhaps will play a fundamental role towards us improving and making a more resilient healthcare system itself. So thank you very much, Dr. Reddy, Sharad. I appreciate the conversation. Thanks.
Thank you so much. Another excellent discussion. And for me, the entire piece actually hovered around looking at social determinants contributing to 70% of healthcare. And the other piece was reimagining the entire way healthcare needs to be planned. With this, we get on to the third session. So while we talked about digital technologies, there are processes and protocols which are needed to validate these technologies. And the need is because you need to understand what kind of outcomes can you expect from solutions which are into the market. And so therefore, there's a need to build processes. There's a need to build infrastructure that can deploy those processes to validate those technologies. And this is where the concept of evidence labs comes in. And when it is, for this session, I would like to invite our chairman and CEO, Chattopadhyay, ma'am. So ma'am will be moderating this session along with our experts for this panel. I would now like to invite Professor Udaya Desai to come in, sir, Founder Director, IIT Hyderabad, and now a Plaksh Fellow. I would also like to invite Professor Sarang Dev to get onto the stage, again from ISP into the operations management field, and also associated with the Max Institute for Healthcare. And I would want to now invite Sri Madhav Joshi, CEO, India Health Fund. We've had discussions around this, but I think it'll be great if we can structure the discussions. Ma'am, over to you.
Thank you, Ambuj. The previous two panels and the regulatory keynote actually paves the way to the discussion of this panel, which is about evidence labs. Especially when we are looking at digital health and healthcare solutions that are going digital, I really did, and I see Dr. Surinder Singh is not here. I did not hear the voice of our regulator, CDSCO, talking about what happens for digital health, what kind of regulations will be followed for digital health. It is probably a Class A device, what he referred to, and within Class A, digital health was not actually alluded to. How do we, and all devices that would be in the digital health space would not be Class A. Some will be Class B as well, could be Class C at times, but A and B definitely. In that case, who actually builds the regulatory framework? Is there a need for a regulatory framework? So let's ask ourselves, who is bothered about regulation of digital health? Is the consumer bothered? Is the government bothered? Is the health? So there are three aspects: the health provider, the health seeker, and the government and policymakers. Who gets impacted if we do not have any regulation around digital healthcare, around the digital health solutions. And if we can come to a conclusion after this 20 minutes that, okay, this should actually be free and open, the system will take care of the regulatory processes. There's no need for regulation. Or is, even to do that, we need to build evidence. And how do we build evidence? So what we will do is, maybe first want to hear your views about what you think is the need to manage digital health solutions. And I would request each one of you, and we'll start with Professor Dedesai, on what do you think is the requirement in your view of a evidence lab building evidence for digital health. We can decide who will use that evidence, but do we at all need to build evidence? Professor Desai.
Let me say two things at the beginning. Maybe they are somewhat not completely aligned. One is, I'm not a great fan of heavy regulation. I said that yesterday also, and I keep saying it all. Sometimes I think it is, heavy regulation is anti-innovation. But on the other hand, some degree is required. Now, having said that, I think the concept of an evidence lab for digital health is very essential. It's fantastic. Because today there are many people who are providing digital health services. To some extent, I would say, at one time I was involved with a startup called A3, remote monitoring tech, that is anywhere, anytime access remote monitoring technology. It started about 15 years ago. It was basically about digital health. But the point is that people are not very confident of using it. They are not sure as to what they're getting out of it. And all of us, feel very comfortable if something is certified. Wherever we go. When I buy some products, today if I buy medicines, I know it has been certified, by an agency. So I feel more confident about buying those medicines and consuming them. Even simple things like food when I buy. I know FSSAI has certified it. I feel a lot more comfortable. So I think it is, yes, essential to have it. Okay. In that sense, I think that, to me, in my mind, there is no controversy about having an evidence lab or whatever name that you kind of select for it. And digital health right now, it's kind of, it's a very loose thing. Okay. I know many people who are very active in digital health. In fact, most academic institutions contribute a lot to digital health rather than the conventional healthcare system. But what is required in evidence lab? I think what is it? You have to create trust. If I say something is good, why would someone believe me? Who am I? I could be. Just because I'm a professor at an academic institution, there is no reason. So I think one big challenge is how to create trust. Whatever it may be, good, bad. Like in US, we have the FDA, and somehow people have developed a certain amount of trust. There are pros and cons. Okay, I've heard in private people also talking that, oh, this happens, that happens, etc. But still, by and large, we feel if something is FDA approved, okay, I'm more confident of accepting that particular product. Could be a medical equipment, could be medicines itself, etc. So trust has to be created, and that is not easy. Creating trust, it's a long time process, and a structure has to be created. You need, at least in the beginning, people who are working on it with impeccable record. There should not be any self-interest, any relationship with commercial organizations and other things. I think that is one particular part. The second part I would say is authentication. How do I authenticate whatever I've done? Earlier, yesterday I talked about collaborative kind of authentication in a way. How do I validate? Because there is an organization which says this is good. Initially in the mind being, who is this organization? Just because they are saying, should I believe it is good? How do I go about verifying it? Now, I don't have a clear answer on these things. These things require a lot more thought, but I think this would be required. The third is, I think, alluded, and I'll just leave it at that particular point, that 2 points, if you permit me. One is timeline. I won't spend time on it. Anytime, if I have a digital health product, I give it to the evidence lab, I want it in a fixed time. I think Dr. Singh talked about it a lot, so I won't say. The last part, which I'm not clear, even in Dr. Singh's talk, broadly is that suppose the evidence lab says that, yes, this is good. If something goes wrong, who's liable now? Does evidence lab have, does FDA have any liability tomorrow if a drug fails in the market? I know I'm an electrical engineer, by the way, so I'm just to make it clear, I'm not from the medical fraternity. So I really always ask myself, in this case, when the products are defined. Same thing with standardization bodies. Standardization bodies are not liable. It's the guy who manufactures. So I leave it at this point and then come back to other things that you have. Thank you.
I think these are very important points. You alluded to less regulation, then you talked of trust, you talked of liability, you touched upon authentication. And I think let's hear the other two panelists. Madhav, can I get your views on this?
So I'm going to start on the basic premise that healthcare works on evidence. There's no evidence, there's going to be no adoption by users or providers. So I think that's fundamental. And as we've heard previously, there's a very well-defined pathway for evidence in the conventional sense, whether it's for therapeutics, vaccines, or devices. Digital health is where it gets fuzzy. And so the question of the need for evidence, I think, is well established in all. The question is, how do you go about it? And there could be many ways. I don't think there's one straight pathway towards it. But the evidence lab, in the absence of a well-defined structure, at least provides an approach that has the potentially the alignment of all of the relevant stakeholders to at least make sure, to the point that Dr. Desai made earlier, trust is built in the right way, consistently, and with the parameters that have everybody's consensus and obviously address all of the quality checkpoints that need to be addressed. So that's my 2 cents worth.
Thank you. Sarah, can you have your views?
Yes. I've been grappling with this question because when we think of digital health, there are so many types of interventions that we can think of. If you're thinking of a drug, then we know that more or less it's going to have a therapeutic effect. If you think of a medical device, many of them are used for monitoring or measurement. I think digital technologies, digital solutions run the whole gamut. They can be used for monitoring, they can be used to generate recommendations. Doctors can act on those recommendations, patients can themselves directly act on those recommendations and then nudge the clinicians, please do this to me because I've got this alert. So I think the space is very complicated, and as a result, the evidence that we look for will also have to be multifaceted. What kind of evidence do I want to be generated for digital solutions which are directly used by patients? Because we know that there is a digital divide, and even people who think they are digitally adept may not be able to interpret all the digital signals that come out of a solution. Doctors, there is a separate challenge of how do we convince doctors that the digital solutions are giving out the right signals or right information. I come from a business school, so I can't think about anything other than a 2x2 or a 2-dimensional map, So it would have to be, what is the intended use of a digital solution, and what are the different types of evidences that you would want for each of those uses. It may be, in drugs, again, we think about safety and efficacy, right? Is that the right framework for digital evidence? I'm not sure. For medical devices, we think about standards. Maybe we need standards for some, we need safety and efficacy for something else. And I think that's probably the important role that a lab, a digital evidence lab could play, just to lay out the framework. And we heard a lot about, how not to learn from others, countries. I think we could learn from other countries in this case because they are a few steps ahead and they would have made some mistakes that we should try and avoid. We may want to discuss this later. I think a crucial element would be how do we get the regulators to actually inculcate or incorporate digital competence? Because the way I'm interpreting this is the lab would be maybe an independent entity, but at the end of the day, the legitimacy will come when the regulator in the country would say, yes, this makes sense. Now, it's not trivial because I don't know those people personally, but I doubt if they are trained in digital technologies. Many of them may come from, chemistry, biosciences, and this may not be natural. So how do we build that capacity so that the output from the digital labs, gets used in an appropriate way? But maybe we'll talk about that.
Thanks. I think both of you, Madhav and Sarang, you touched upon very important areas. How do we make, even if we collect data, if we try to build evidence, researchers keep doing it. Academic evidences are built, but how does that get legitimized as, because this is not just a research paper that we are talking of. We are collecting evidence for policy changes, or we are collecting evidence for consumer benefits, or we are collecting data so that the regulation is proper at the right level. So the next question I have for maybe Dr. Desai, you talked of regulation. You're not a great fan of regulation. So let me ask you a question on regulation. I think that would be good. If we have to build a system, if you have to build a system, and what kind of data do you think, what would go to the regulator, and what would the regulator do with it? Because I understand your sentiment, and how do you think this can be done? And we'll come to Madhav and Sarang with two different aspects of the provider and the consumer.
So you're saying what kind of data I should give to the regulator?
Yeah, what would be that path? How will we connect to the regulator? Why will they take our data? Who are we? How does that happen?
So that one has to develop. One is a relationship with the regulator. There has to be a dialogue and communication, and the data that I provide should be valuable data. I just can't give some numbers. So if I can say that this data is coming from, suppose I have say oncology data, and I'm saying it's coming from Tata Memorial Hospital. We collected it in collaboration with a leading oncologist. I think Badwe is in charge. I think he's still there. Okay, so in collaboration with Dr. Badwe, or maybe from Nanavati Hospital in collaboration with my good friend Nagaraj Huilgol, who's the radiation oncologist out there. Okay, so then I think the regulator is more likely. On the other hand, if I do an experiment in my lab in IIT Bombay or whatever, IIT Hyderabad, collect data and go to the regulator, I don't think the regulator is going to pay too much attention in spite of having the IIT backing. Because there has to be, in some sense, the core expertise. Okay, the people who have the core expertise have to be involved in collecting the data, also in terms of saying that yes, this is good valid data. And I've had a lot of discussions about this, not from radiologists. Patkar, I think many of the radiologists in the audience may know about it. I think he was the president also of the Indian Radiology Association. Now, Patkar was very critical of a lot of things that I used to do, and even in COVID times, he said, this is useless, I'll never use it. And he has a good friend, so he could openly tell me that. So I think, if I involve Patkar in collecting the data and then go and say that, yes, it is us who did as a technologist, then we have Dr. Patkar who is involved in it, I think he's likely to accept that. I would say that has to be the approach.
So, it is about collecting data along with clinicians and along with the regulator themselves to have a process so that what Sarang mentioned, so that there is a legitimacy of whatever is collected.
In fact, I would add one adjective, though people may hate me for this, is we should have both sides. People who have established a reputation. You trust them.
Yeah.
Okay. So I think otherwise, it takes time to develop a reputation. And I think so when you say, people, experts in different domains, they all should have a strong reputation.
Sure. The key opinion leaders. Fantastic. So, Madhav, as IHF, the work that you are doing, and I understand that you have an interest in an evidence-building laboratory. So, what are the aspects that you are looking? Are you looking at long-term data collection, longitudinal data so that the government can take actions and understand what is happening with the introduction of digital healthcare solutions, what would be your basis and your interest in doing an evidence lab?
So, India Health Fund is an initiative that was set up by Tata Trusts, particularly to focus on enabling deep science and deep tech to strengthen primary care by ensuring better access and affordability for people who need it but don't have access to the technology, and that's why it comes from the trusts. Our view is that digitization is happening across the economy. Healthcare is not lagging behind anymore, and that's the one thing we can thank COVID for. But it's happening at a very uneven pace. And the risk we run with digital health is the opportunity will be lost if we don't ensure inclusivity built into it now rather than try and catch up 20 years from now. So our approach to digital health is in ensuring that the solutions we enable are designed to improve access, affordability, as well as resource efficiency for the health system. And in doing that, we make sure that the data that is used, and this is to Dr. Desai's point, the data that is used is representative of the various patient segments so that it provides the right use cases, the right investment cases for both the public and the private health systems. Because we've got to take into account that we've got a fairly unique situation in India where 70% of healthcare spend is out of pocket, and it's got to be relevant for both the private and the public health systems. And that's really how we're curating our work around digital health, evidence in particular. And then to the point that you made earlier, making sure that it is represented effectively to both the decision makers, the users, and the providers, while also making sure that then digital literacy is built among regulators as well as healthcare workers who will eventually be delivering it.
Thank you. Sarang, you know, I have a Samsung watch, that smartwatch, which tells me a lot of things about my heart rate and so on and so forth. Is that good enough to go to a doctor when there is an indication of a deviation? I'm not sure. And they always say this is not for taking decision-making device. It is just an indicator, an early indicator. The question is, I have not seen, even for an Apple Watch or a Samsung watch, rating, a comparator rating of these devices that are available. As a consumer, can we do something for the consumer so that the consumer, when they use devices or digital health in any format, they feel more comfortable? What should we provide them?
Sure. I'll quickly just respond to one of the earlier comments.
Sure.
Because I really liked what Professor Desai said on the credibility of the evidence. If you have subject matter experts from different areas coming together, a technologist alone cannot generate the evidence, you need clinician. I think another element of making the data credible, legitimate, is following the structures and processes that exist. For example, if you want a drug to be approved, I'm sure you have to do a clinical trial registry. It's not trivial, because for you to register that clinical trial, you have to write a protocol. You'll have to say, these are the outcomes, this is how I'm going to enroll my subjects, this is how we'll take care of attrition of subjects, so on and so forth. So if a similar framework was available for digital therapeutics or any digital solution and the researchers followed, that would be a notch above, because I agree with you, researchers' job is to generate evidence. But I don't think every piece of evidence that gets generated is going to be useful to approve a digital solution. The two are very different things.
Absolutely,
right?
because there are inherent biases in any research.
Or the objective may be different. Right? But yeah, coming to your point about consumers, I think, I mean, we'll have to do a survey of sorts, but I don't think a lot of these products today are bought with the intent of intervening in any care pathway. I could be wrong. I don't have watch, so I don't know much. But I think today we are just kind of saying, okay, looks good on my wrist, or there's some fancy, things that I can tap, etc. Very maybe just 0.01% or less, maybe saying, oh, this is giving me useful health information, and I will actually use it to first make decisions on my own way, and then maybe communicate to the doctor. So yes, we do need, comparators and what are the right attributes and so on and so forth. I don't know how and when we will reach there, because while we can come up with those standards, consumers need to understand that those are relevant attributes, and doctors or clinicians need to also, agree that these are relevant. Not everything that the clinician thinks is relevant is available in the digital solution, and then the clinician has to marry what comes from the digital solution with other inputs.
Yeah.
I mean, not consumer facing, but we've been working with some AI technologies that do diagnosis of, TB was mentioned earlier, and other chest ailments by reading x-rays. And we are finding that the radiologists think that this is not, one, useful, and that they are already so good, they think, that they don't need this AI solution. And we need to generate evidence to say, what's the objective expertise versus what perceived expertise is. So I think while consumer focus is important, the providers would also have to be brought in at the same time.
Yes. So it's the provider and the consumer who comes in building, even if we are talking of protocols. And that brings me to my last question very quickly. If you have to build a framework of collecting evidence for a world that will be increasingly digital in nature, personalized medical, so you are empowered to handle your health yourself. I think we are moving towards that. In that kind of a scenario, where do we start in terms of building protocols? Do we actually, and this is a very quick, so what is your view in terms of where do we start building our standards and frameworks? Do we actually wait for the government to do it, or do we actually start building, and where do we start building? Anybody?
I have the mic. I mean, we can, so the start would have to be, it's difficult to come up with standards. You can start by generating evidence and possibly having these discussions with, people who matter. So CDSCO may be the right place. Because eventually for a framework to be legitimate, for, procedures to be legitimate, for something to be approved, it would have to be through the regulators. Yeah, I mean, I'll stop there.
Okay. So there's no freedom from regulator. Yeah.
So I would argue that we're probably a bit far away from personalized healthcare right now. And the priority for digital solutions should probably be to ensure early screening as a means of enabling early diagnosis, treatment, and eventually prevention. So to my mind, it's really about building the approaches and framework that can enable use in primary care, low resource settings, which can then overcome both the infrastructure, the financial, as well as the manpower limitations. And that's the big advantage that digital solutions can bring as a supplement to the existing health system.
So I don't think we need to have a complete sort of approval from the regulator. What can be done is, I'll give an analogy, not necessarily in healthcare, but electrical engineering. For example, certification. You buy cables, you buy switches. Okay. Now, there is no regulator which necessarily certifies the electrical switches. I mean, they can give you a shock, right? And you can die. Okay. Or you can get debilitated, whatever. But then there are organizations which have been recognized by government that you certify it and will accept it. In fact, IIT Bombay for a long time used to have a short circuit testing facility. And the professor who was in charge, made money. So it was not something like a philanthropy work. And industries in Bombay and perhaps all over the country, okay, used to come there to do the short circuit testing for every electrical item, maybe electrical switch or whatever electrical components were there. Okay. Now, similarly, what can be done is that if IKP sets something up, the government can say that we have trust in you, we have faith in you, so you give the certification, and we recognize that certification. Personally, I think that is a better approach than the government trying to do everything. In the process, what happens, everything gets centralized and things don't move. And I think decentralization to me also is very, very critical, and somewhere we should convince the regulators that please decentralize. There are enough private bodies also which are good bodies and can do good work and give good results.
So I think with that, this is the perfect note to end this conversation, and we will pick your brains later when we actually set up, that's what we are intending to do, evidence lab for the digital world that we are going forward to. And that brings us to the close of this session. Lunch is waiting. Thank you. But before that, we need one photograph.
Take any questions from the audience.
Actually, it's getting so
Getting
late.
too late.
Because
Everybody's hungry.
Everybody's hungry. 2 o'clock, we have another session. I have to be there. So I just took that liberty of not taking questions.
Financing structure space. We're then going to take the session on to a discussion around emerging business models, where we have 3 startups who are coming in from different sectors, and they're going to talk about what kind of business models they've been developing, and being moderated by Dr. Chintan. The idea will be to bring out the value proposition or the differentiators within each of these startups and their business models, and to see, connect it whether does this lead to some new financing structures which they are seeking out into the ecosystem. We would then follow it with the role of philanthropy. So what is the role of philanthropies in basically, addressing this entire social impact space? And we'll wrap it up with a discussion around the impact investment space. So with this, I would now like to welcome Dr. Chintan Vaishnav. Sir, the stage is yours. So you have a slide up here?